Hi, welcome back. Now we're going to talk about the major studies that have been conducted over the years on alcohol and drug treatment and the assessment batteries that have been put together to collect information that is useful in evaluating treatment outcomes when different types of treatment are either compared or we're trying to determine efficacy against an untreated control group. And the two studies that are indicative of the state-of-the-art in treatment effectiveness research are Project Match and the Marijuana Treatment Project. Match, as you may recall, was a study conducted in the 1990s to evaluate treatment matching with different types of psychotherapies, talk therapies for people with alcohol problems. And the battery that was put together for Project Match, which studied approximately 1,000 patients, was quite extensive. And at the beginning, at baseline, it required 3 separate sessions to collect all of the information. This might be a bit of overkill, but it does provide useful information depending on the type of research that you're doing. Initially, patients needed to be screened, and you need to have a set of eligibility criteria that would determine who is appropriate for treatment and who is not. So basic eligibility in Project Match was evaluated with a set of quick interviews that could be conducted by telephone or in person called the Quick Screen. After that, if a patient was found to be eligible, they were invited in for a set of interviews with a trained research assistant and a clinician to do a diagnostic evaluation. And this would confirm the information that was collected in the Quick Screen and begin the process of qualifying a person to be randomized to one of the treatment conditions. And one of the most important things here is evaluating the severity of their alcohol dependence and the symptom severity in other areas. Prior to the beginning of treatment, more information was collected about the person's alcohol and drug history, as well as their personality characteristics, attitudes, and psychopathology. Outcome variables were measured at baseline and repeated at various follow-up interviews at the end of treatment and at 3, 6, and 9, and 12 months after treatment. And outcome variables were divided into primary and secondary measures. There are so many things that we could measure that might be sensitive to treatment that if we put them all in, by chance, we're likely to find statistical significance in 1 out of 20. That's why, a priori, at the beginning of the study, researchers are asked to specify what their primary measures are, where they would predict the most change, and what their secondary measures are, where you can do more exploratory analyses. For Project Match, the primary measures or primary outcome measures came from the timeline follow-back calendar procedure, and there were 2 primary outcome measures that were assessed at baseline. Percent days abstinent in the preceding 3 months, and number of drinks per drinking day. So if a person was drinking only 5 or 6 times, but each time they lost control and drank 15 drinks, then their drinks per drinking day at follow-up would be 15 drinks, even though they only drank for part of the time. Secondary measures that were considered more for exploratory purposes to evaluate the Project Match treatment interventions were the negative consequences from drinking, other substance use, social functioning, and psychological functioning. And as you recall, these measures conform to the domains that are typically measured in treatment outcome studies. Here are examples of two types of treatment settings where patients were recruited from in Project Match. One, a set of outpatient programs in 10 different settings across the country. And the second one, patients exposed to aftercare having been recruited from a residential treatment facility. For the outpatients, you can see that they were abstinent prior to recruitment into treatment 34% of the days during that prior 3 months. Many of them were drinking every day, but just prior to admission to treatment, they stopped drinking or they cut back, or they had to because they were arrested for a drinking and driving offense. For the aftercare patients who tended to be more severe in their dependence and in their alcohol problems, there were even fewer percent days abstinent at baseline. Drinks per drinking day in the two groups differed significantly. For people considered eligible for outpatient treatment, they were consuming an average of 13.5 drinks per drinking day. For the aftercare patients, it was 20.5 drinks per drinking day. That's an enormous amount of alcohol to be consuming. And it helps to explain the number of SCID dependence symptoms, which is the next item. For the outpatients, it was 5.77. For the aftercare patients, 6.79. Remember that the SCID is a semi-structured interview asking about different symptoms of dependence. For DSM-4, at the time when this study was conducted, the potential number of symptoms that people could have was 7. So most of these patients were severely dependent. Prior inpatient alcohol treatments, 45% of the outpatients had prior treatment, 58% of the people recruited from residential settings had prior inpatient alcohol treatment. So this is an example of the types of alcohol treatment variables that are important to measure at baseline and to consider in terms of outcome measures when people are followed up. The second study that serves as a good example of assessing treatment outcomes and measuring baseline characteristics is the Marijuana Treatment Project. MTP had a variety of different assessment procedures put together by a group of researchers that began with a screening questionnaire to determine availability and eligibility, asking about demographic characteristics, current alcohol and drug use, lifetime dependence history, and medical and psychiatric histories. These were quick screening questions to make sure that the people who were recruited into the study were relatively pure marijuana users. They also completed a structured clinical interview for DSM, a SCID, and out of that, one was able to determine whether they met criteria for marijuana dependence. The timeline follow-back interview was used to obtain weekly estimates of marijuana use, alcohol and other drug use, And the weekly estimates went back 3 months. So day by day, one could plot how much they were drinking over that period of time of 3 months. Quantity of marijuana, alcohol, cigarette use was also measured in the timeline interview. Every day, people reported how many drinks they had and what types of drugs they were using. And the addiction severity index was also given. The addiction severity index is used by many treatment programs. It covers lifetime and current alcohol and drug history, the person's medical history, employment and social supports, legal history, and psychiatric severity. In many studies, the investigators take pieces from one battery or another. So MTP did not use all of the ASI scales, just some of them. Self-report questionnaires that were also used in MTP and are typically used in many other treatment studies are measures of depression, like the Beck Depression Inventory, measures of self-efficacy or a person's confidence in being able to resist the temptation to go back to using drugs or alcohol, reasons for quitting. Usually you want to measure a long list of problems, and we did this in MTP with the marijuana problem scale. Often we're interested in a person's readiness to change or their stage of change, ranging from pre-contemplation to a person actively being engaged in stopping use of alcohol or drugs, and measures of anxiety. Often it's good also to get a urine screen and objective measures of alcohol consumption. Inclusion criteria can be measured with these intake variables, and these are the inclusion criteria that were used in MTP. We wanted to make sure that people were using cannabis recently, that they met criteria for a substance use disorder, a cannabis use disorder, that they're not involved in concurrent therapy in other programs, because we wanted to see what effect the study treatments had on them. And we wanted to make sure that they didn't have other medical or psychiatric conditions which would interfere with their treatment. Here are some findings from the intake assessment battery that describe the sample that was recruited into the marijuana treatment project. The years of regular marijuana use was almost 18 years. The average age of these research participants was about 33 years. So many of them had been smoking marijuana, and many of them having problems with marijuana for a substantial period of time, since their mid-teens. Number of dependence symptoms, DSM symptoms assessed by the SCID was 5.36 out of 7, and the number of marijuana-related problems was 9.38. The distribution of days of recent use during the past 90 was skewed in the direction of daily use. So most people were smoking every day. And on average, they were smoking marijuana chronically 80% of the time during the past 3 months. The number of joints smoked was a mean of 2.9, an average of 2 or 3 per day. And the number of hours that they were high per day, as recorded in these interviews, was a mean of 6.6. So for the most part, these people were high a substantial portion of the day. Many of them were driving and going to work. These are all important targets for treatment. And in a treatment evaluation, if you can measure the distribution at baseline, you can then look at it at follow-up to see if it shifts in the right direction. We can't expect everyone is going to be abstinent, but many people might be able to reduce the number of days they're smoking, the number of joints they're smoking, and the number of hours that they're high. And these are all very useful outcome measures. Here's an idea of some of the dependence symptoms that they reported. 95% said that they continue to use marijuana despite physical or psychological problems caused by their substance use. Many of them just could not stop. 68% of them said they need more and more marijuana to have the same effect that they had previously to get high. And a remarkable 78% reported relatively serious withdrawal symptoms. So if they got up in the morning or they didn't have a joint to smoke for a few days, they reported appetite disturbance, sleep disturbance, night sweats, headaches, and irritability. So these data are very useful clinically to evaluate the severity of a dependence syndrome in a group that is being exposed to treatment. And they demonstrate the value of assessing a variety of characteristics at baseline in order not only to conduct good follow-up evaluations, but to conduct predictor analyses as well.